Hello, good morning. I'm Meredith Craven, the Director of GI Health Psychology, and together with Nielsen Fernandez Becker and with the help of Deborah and Shannon, we've been planning for months for Dr. Drossman to visit us. So this is part of a wellness initiative. And we're so happy to have Dr. Drossman with us today. And I'll just, do you want me to read your bio again?
Again.
Okay, well, I'll give some highlights from the bio. So I'll just give some of the highlights. So Dr. Drossman received his MD degree at Albert Einstein College of Medicine and specialized in biopsychosocial medicine and gastroenterology. He has established multiple organizations to advance patient-centered education and treatment disorders of gut-brain interaction. He founded the Rome Foundation and served as the president until 2019. And he's been the senior editor of basically all of the Romes. And as a gastroenterologist, Dr. Drossman consults or manages the care of difficult to diagnose and treat patients with DGBIs. As founder and president of Drossman Care, he produces educational materials to teach communication skills and patient-centered care, and has published many peer-reviewed articles, over 500 articles and books chapters, and serves on 6 editorial and advisory boards. So there are many, many more things that we could share, but we'll let him get started. And as a reminder, please fill out that survey online or on paper, and we'll jump in.
Okay, well, thanks. So maybe to introduce this segment goes back to my history. I wasn't sure if I wanted medicine or psychiatry. And chose medicine because I thought it was pragmatic. I wanted to treat patients. And in the course of my career, I decided I wanted gastroenterology. And at the same time, I was a little bit confused with some of the patients I was seeing as an internist. This is when I was in the military, during the Vietnam era in Texas. And I was seeing patients and their symptoms were just not mixing with the evidence that I was seeing. They have symptoms that weren't comparable morphologically and structurally. Came across a guy named George Engel. Anybody here named George Engel? He coined the term biopsychosocial model in the seminal paper in 1977 in Science. And that turned the world upside down, at least for those involved in psychiatry and psychosomatics, because he challenged the dualistic system. And I'm going to get into that in a minute. But that fascinated me. And so I went for training with him. So I had psychiatric, psychosomatic training before I went into GI. And I remember as a first-year fellow trying to predict which patients had findings on endoscopy and which didn't, with pretty good accuracy, just by the history. Many of you could probably do it now too, but it was kind of interesting. And then from that point on, I started teaching the integration of the biopsychosocial model. Even when I was a fellow, I ran a program, a monthly program for the faculty on difficult patients. So that led me to the next 45 years of doing what I'm doing now. That's the short story. And what I want to do now is convince you the value of good communication skills. So let's start. Next slide. When I was seeing patients for a month, I decided I would. Now, my practice are the ones who see the more complex patients. They come to me from the Mayo Clinic or from, yes, half of them come from out of state. They're very much like the patient I presented yesterday. They're very much like the guy that we saw today. And they come in with these kind of messages. So I did more qualitatively recorded what patients said. And this is what they said in that month. Doctors don't believe me. There's the issue of credibility. There must be something wrong. The question of something's being missed. The question of is it real? One woman was sitting on the table saying, I'm not going to leave till you open me up and find out the problem. You don't think it's in my head, do you? So it's getting into the question of, is this psychiatric? Sometimes I feel like I'm going crazy. The question of a sense of isolation, nobody knows what I'm going through, how they've changed. I feel like I'm not the person I used to be. I feel so alone. I feel like a burden to my family. And we've done focus groups and published it, which is a big element for patients with IBS. Their spouse doesn't understand them and they feel very much alone. No sense of control, even to the point of, have I caused some damage to myself? I feel like a failure and I feel ashamed. These were spontaneous statements that came out. If you listen to them, you'll find them. Next. We did a survey with the IFFGD of almost 2,000 patients, and we asked them about their satisfaction with care. And what you can see is the degree of very satisfied and extremely satisfied. We're talking about less than 10%. We're talking about 75%, not a bit, all or a little bit. And the same thing with the medical care by the physician. Only about 23 or 24% were very or extremely satisfied. So there's a big gap. That's what the Institute of Medicine did in 2001. They wrote a paper called Crossing the Quality Chasm, and they coined the term patient-centered care. That there's such a gap between the way doctors and patients see the problem, that you have to move toward the patient being responsible for care, which was pretty groundbreaking at the time and not well accepted. And to this day hasn't been well accepted without certain groups like Rome doing that. Next slide. So what are we dealing with? We can't spend time to see patients. That's the big thing I hear. Who has the time to spend with these patients? We have increasing administrative tasks. Insurance reimbursement favors procedures. One fellow said, why spend an hour with a patient and make $250 when I can do 4 colonoscopies and make 3,000 or more? And so you have the EHR, which extracts your time. There are benefits, but there are limitations. This, by the way, was published in Gastroenterology about a year ago. Next slide. So look at this pie chart. Look at the 10-year difference between 2005 and 2016. In the magenta, face-to-face time with the patient has gone down to half in 10 years. And EHR and desk work has tripled. What are you going to do? This is the system that we're dealing with now. Next slide. Well, I want to go now to the concept that I learned from George Engel, the biopsychosocial model, which is the concept of mind-body dualism, which is the way we work consciously and unconsciously with patients around illness and disease. Illness is the patient's perception of health. Disease is objective abnormality. So when we're seeing a patient, we're going to try to reconcile both. Correlation is about 0.3, by the way. So basically, Western medicine has gone between the concept of holism and dualism. Holism is what Aristotle and Hippocrates say: you treat the whole body, the mind and the body together, not separately. And dualism came about in the 17th century when René Descartes brought up the idea that the mind and body were separate. Now, up until that time, the human body couldn't be dissected because the church hailed dominance about medical care, and you couldn't dissect because the spirit was thought to be in the body. Now, once Descartes came and he said the mind and body are separate, then the spirit was lifted from the body into the mind. So res cogitans, the thinking mind, versus res extensa. And that allowed for dissection and autopsy. And it led for the sciences that followed: pathology, histopathology, nuclear imaging, CT scans, and the like, to make a diagnosis of disease, not illness. Okay. So science became morphological. Diagnosis was based on morphology, but yet that's only half or less of what we see. We see patients with symptoms that don't have morphology. And back in the 17th century, when they complained of symptoms or had behaviors, they were thought to be possessed or insane, and they went into the insane asylum. It wasn't until the 20th century that mental health went into the curriculum in medical schools. So there's a permeating unconscious view that if you don't see something, it must be nothing's there or not real or psychiatric. We surveyed the AGA and that's what we found. That's what doctors think. So that creates this hierarchy so that disease is verifiable and organic and illness is functional, the patient's perception of ill health. How does that affect us? Next slide. Great cartoon. Did I show this yesterday? I don't, no. Where is this from? What magazine? New Yorker. And it has the patient in the bed, the internist, and the psychiatrist waiting. The internist, who has this, if you're interested in nonverbal, this somewhat sardonic smile, saying the old body checks out. Let's see what Doc Atkins here makes of the old mind. And he's literally wringing his hands to get rid of the patient because the studies are negative. And the psychiatrist waits expectantly. And this patient has closed lips of non-acceptance for clear reasons and very surprised because why should it be assumed that the absence of a structural abnormality means psychiatric? That's the way we think in our society. Next slide.
I think it's also interesting that it's a woman too, so adding that. Yeah.
Yeah, right. And that is the prototype, isn't it? This was in the 60s, but you'd still see it now. So I mentioned the Institute of Medicine. It coined the term patient-centered care. And traditionally, it became the issue of the doctor calls the shots, the patient listens. The patient's participation is limited, may not elicit psychosocial issues, does not address the impact of the illness. The woman I saw today, I said, who had questions about her illness and said, what's the quality of your life? And she couldn't even come up with asking those kind of questions are very relevant. Doctor selects the patient, treatment patient complies, doctor makes the decisions. And then they said the patient has to get involved. And then the patient makes the final choices. They equally participate. It's called the collaborative care model, patient-centered care. Patient is active in creating the information, then doctors respond. The first book talks about all of that. The second book are narratives from patients in the concept of narrative medicine where the patients tell their story. The doctor addresses psychosocial factors and uses communication skills, provides options for treatment, and then they decide on the plan of care mutually. Next slide. This is my most detailed slide. It's an evidence-based study we published in Gastroenterology. It's a working team where we did a systematic search and we looked about whether communication skills improve patient and provider experience. What we found was that interventions targeting patient and provider interactions improve population health, patient and provider experience, and costs. It's the first review that's showing that it reduces healthcare costs if you do good communication skills. And the rest we can go through. Using a Delphi approach, it led to recommended practices. You prepare before seeing the patient. You look at the record beforehand. You listen intently while sitting down, active listening, formulate an agreed agenda, connect with the patient's story, and explore emotional cues by naming and validating the patient's feelings, which we did with the first guide today in the inpatient. Next slide. So what is the benefit? It improves diagnosis and clinical decision-making. It is more efficient. You can gain more information in 30 minutes using a patient-centered interview than the traditional history, physical, asking a slurry of questions. It creates a collaboration of care, establishes meaningfulness. What is meaningfulness? You've heard of hedonics and eudaimonics. Hedonics is pleasure. If I said, what gives you pleasure? Food, travel, sex, that's hedonics. But what's eudaimonics? What gives you meaningfulness in life? If I asked you that, you might have a very different answer. Helping patients. feeling gratification for the things that I do research on, find answers. So it establishes meaningfulness. Doctors like to see patients when they do it this way. It saves time, and then you have the benefits through trust, engagement, and so on. So that's kind of a philosophical, but let's get into the details. Next slide. So when you see a patient, it's information gathering, it's providing education, it's establishing the therapeutic relationship, and it's implementing treatment. It's not just taking a history. You're doing more than that. Next slide. Okay, hit the button again. So this is talking about, there are certain key elements that we think are important in establishing a good relationship. One is satisfaction for patient and doctor. Now, you know about HCAHPS. That's really designed for reimbursement. Is the room clean? Did you get your medication on time? But if you ask patients, what do they mean? What makes them satisfied? There are 4 items that come up all the time. The doctor has to be seen as technically competent. The doctor has to be seen as humane. The doctor has to understand their psychosocial milieu, their world, and they have to provide the information they want to meet their needs. And that's too much information is negative, but providing what they need or want is good. So if you go through all the test results, that may not be helpful. So that's getting satisfaction. Next slide. When I was at Hopkins, we did, Johanna Ruddy and I did a workshop, an all-day workshop, a day for the faculty there. And we also did a survey of the patients that the faculty saw. And we asked that I had created a physician relationship scale for the patient to rate doctors. And I think you took a physician-patient relationship scale to get your values of what you see in patients. Anyway, this was what we did with the patients. And then we also had developed a satisfaction with care scale. So what we did here was say, what are the elements that the patients see in their doctor that relate to their sense of satisfaction? And it's probably no surprise. Someone I like, knows about my case, accepts my feelings. These are the correlations, straight correlations. And we did factors and things like that. On the negative side, seems rushed, is not concerned about me, is rude, interrupts, doesn't do a physical thing. Patients expect to have a physical thing. So that's satisfaction. Next. The next element is engagement. You can hit the button again. And engagement means that the two of you are working on the same game plan. You're working together toward common goals. And a lot of that is nonverbal. What do you see here in this picture? Close.
Closeness, paying attention, sitting down with a patient.
Close interpersonal contact.
Mhm.
Good eye contact. If you heard them, it would be affirmative. A gentle tone of voice, not shouting. Affirmative nods and gestures. You know, non-verbally, even when I'm giving a lecture, if I'm giving a lecture, and most of you are going like this, I know it's going. And most of you are like this, or on your iPhone, I know it's not going. So that's what's going on now. You're looking for engagement. The group is engaged right now. So that's what you need to do to go from point A to point B. You have to establish at the very beginning a sense of engagement with your patient. Next slide. Hit the button again. And then we get into the idea that when patients are satisfied, doctors are satisfied, and vice versa. If it's collaborative care, they both are satisfied. We talked about likability before on the other graph. The elements of burnout relate in part to not enjoying the work you do. But if you enjoy seeing patients, and then that reduces the burnout tendency. It even reduces malpractice, because malpractice is not related to the technical error you made, but the communication around it. I've seen big malpractice suits where the doctor doesn't tell the patient what happened and they find out later. But if the doctor goes and said, here's what happened, I'm very sorry this happened, I'll continue to work with you, then that reduces the tendency.
You started cooking yet?
So let's go through this. What I want to do now is go through the elements of good communication. Sorry, is there a question?
Meredith, that's all. Okay.
I want to go through the elements, a very simple checklist of what you could do. And we're going to use that to look at some videos where there are problematic issues coming up. And we can select some of them based on your interest. I know 3 or 4 I want to do already from what we talked about yesterday. By the way, this has been a very, very nice group. I really enjoyed this visit so far. The first thing is listen actively. Everybody thinks they listen actively, but they really don't if you're with the patient. But I'll give you an example. If you're at a cocktail reception and you're speaking to someone and you're holding a drink and they're holding a drink, you're talking about your children, you're talking about their children, you're talking about your children. And if I were to tap you on the shoulder and say, what did the other person just say? A lot of the time you don't know. Because you're waiting for the other one to finish to say what you want to say. That's not active listening. Active listening is you're intently listening to what they say so that your response will be based on that. Good communicators, good physicians don't say as much. They listen and they use that information to do the next question, and boom, all this information comes out. One person said to me before, how did you get all that information in this 15 minutes? It's because I was listening to what they were saying and I was gauging the next set of questions on it. So that's what to listen actively is. Next slide. Identify the agenda. Now patients come to you with agendas. Most of the time it's not explicit. Maybe they're having a lot of pain, they want you to take care of it. But it also might be, my spouse just had a heart attack and the pain started. You don't know that, but that could be an agenda as well. And then there's these issues of being under more stress. They may not articulate it. Why am I not getting better? Am I crazy? Do I have cancer? Patients don't volunteer to have cancer most of the time. So you do your workup, you reassure them, you send them out, you say everything's okay, and they walk out the door thinking, do I have cancer? Because you never addressed it. Now, if you say, what are your concerns? And they say, I think I might have cancer, you can get into a dialogue and you can provide evidence to reassure them that they don't have cancer. So I came up with 4 things I think you should ask on the first visit. Next. Why are you here today? If this is chronic illness, something's bringing them here now. Some precipitating event. Think about illness as precipitating, predisposing, precipitating, and perpetuating. 3 P's. Precipitating could be something genetic. It could be an early life infection. Predisposing could be early trauma, early life infection, could be socio-cultural factors. Precipitating could be an acute infection, it could be trauma. And predisposing are the accompaniments of chronic illness that get gained, the secondary gain, the things that keep the patient going, or the inability knowing that they can't go back to work, they feel uncomfortable and they stay. So what brought you here today? Next one. What do you think you have? This is the illness schema. I have this infection and nobody's been able to find it. And I think that's what's causing my pain. Well, you can use that information later and say, well, you may have had an infection, but that could have altered your nerves in a way that you're getting the pain now because of that earlier infection, but the infection's gone. So we have to use different treatments to treat the nerves. Next slide. What worries or concerns you have, they have to be articulated. I feel like the gentleman today, he felt he was going to die. They don't, and then the last one is, what do you feel I can do to help? Well, I want you to take this pain away. That gives you an opportunity to say, you've had this pain 15 years. Maybe we can't take it away, but maybe we can get it back to 30% less than you have now. Would that be a good start? That's kind of the way you negotiate that. Next slide. Empathy. a lot written about empathy. I want to show you with, anybody know Brene Brown? I'm sure a lot of the women know. Let me show you this video on empathy with Brene Brown. Just go to the next slide. Oh, this is an example of an empathic statement. Look at the elements of it. The person is reaching out to the other person and stating an affect or a condition that harmonizes with the person. That's what empathy is. It's not providing a solution. Next slide.
So what is empathy and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, I'm down. I know what it's like down here and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
So, you know, it's very valuable to put yourself in the position of the person who is being empath towards, or whatever you want to call it. And what do you see? You see a bridge, you see a connection, which is very different than, oh, this will be okay. Or we'll take care of this. We're going to find out what's wrong. That's not received the same way. So this is Teresa Wiseman. Next slide. Perspective taking, trying to understand their world, sitting where they're sitting, not judging it, recognizing the emotion around it and communicating that understanding. It's not solving a problem for them. Next slide. Okay, validation. Next slide. This is a validation. I can see you're frustrated when people say this is due to stress and you know it's real. When you validate, you're letting them know you accept their reality, even though you may not agree with it. Of course, in this case, do you think it's in my head? Well, you're trapped if you say yes or no, because that's not the question. So the question could be something like, people say this is stress and you know it's real, but that gives you the opening if they feel validated to say, well, you know, stress can affect everybody. Having chronic illness can cause stress. So you get them, you go from what's called pre-contemplative thinking to biopsychosocial thinking, where they're beginning to think maybe there's an association, but they don't want to stick with that to where they do. Next slide. setting realistic goals. That's the analogy I made before. Well, we can't make this pain go away completely. You've had this for so long. It's like arthritis or maybe migraine headaches. But what if we can get you 25% better? I haven't heard a patient who didn't want that. Next slide. Education, next slide, is an iterative process. I think you've seen, I go over with diagrams with the patient. I show them, I get into a dialogue with them to see that they understand. So I get their understanding and then I give them information consistent with frame of reference. So this woman who said, I have an infection, no one's found it, I can talk about the microbiome, I can talk about the alteration that the microbiome could do in visceral sensitization that feels like an active infection, but the infection's gone. All right, then reassurance. Next slide. One more time. So this is also, you want to identify what are your worries and current concerns. You don't want to just blanketly say everything's going to be all right. Always put yourself in the position of the patient. You've got worries and concerns, and they say everything's going to be all right. They don't even know what the problem is yet. So that's what you want to avoid. You want to find out what their worries or concerns are, validate that they have them, and then respond to the specific concerns. And you want to avoid false reassurance, like telling them everything's going to be okay before you've done the history. Next slide. So negotiation gets back to the patient-centered model. We have this medication A, it has this effects and this side effects. We have this medication B, it has this effects and this side effects. What are your thoughts? What would you like to do? So you're giving them the options. And then if it doesn't work and they come back 3 months later and they say it's not better, you could say, okay, what do you want to do now? What are your thoughts now? Bringing yourself a notch down. Because if you come in saying, here's the treatment for you, and they're not better, and they come back in 3 months, they say, what are you going to do for me now? And you have to come up with another answer. You're maintaining that hierarchy, and you're now taking responsibility. And they're absolving themselves of responsibility. And all the data on chronic illness shows that the only way patients get better is they take responsibility for it. So you want to keep that collaborative. And next is be there. Next slide. You can hit the button again. You don't know what's going to happen when patients come in about issues. And as I said, their agenda may be preconscious or unconscious, and it comes up in the context of the visit. Trauma is a good example. I can't tell you how many we didn't know was going to happen until it happened because we put them in a place where it came up. And I can tell you, having done from our research grant, hundreds of women with abuse, they want to tell you their story if they trust you. They want you to know their story, and that gives you options. So be available and listen. Again, don't provide the answers immediately. Next slide. We talk about nonverbals. If this was a longer workshop, we do some exercises in nonverbals. But if you're looking at this ineffective, how often is the patient on a table in a gown and the doctor is standing by the side, literally facing away, holding up the hand to almost push the patient out of the picture and eyes turned toward the medical record, and the patient in return, his arms folded, looking down, arms and legs folded. This is not an engaged picture. But here's one where the doctor's facing the patient is being expressive. They're looking at each other. What is the finger on the mouth mean? You're doing it. Okay.
The thinker.
It's receiving, it's thinking. When you're thinking about something, that's a gesture that you do. So I like that. Next slide. There was another thing is the idea of diagnosis. This comes up over and over and over again, that patients are told they're never given a diagnosis. Why does that happen? Anybody want to guess? Or do you believe that they're not given a diagnosis?
I think sometimes the diagnosis is not given, like, everything's normal, you probably have IBS or this must, all the tests are negative. You know,
Could be.
it could be IBS or, so using very passive type of word or passive or dismissive types of words.
And a study was done where, not this study, but a different study in a practice, where they asked the questions afterward. Did the doctor give you a diagnosis? And they said, no, they didn't give me a diagnosis. And the records show they made a diagnosis. And then they asked the doctor. The doctor said, yeah. I said, probably it's IBS. I'm not totally confident. That comes away as not being given a diagnosis. But if you find ulcerations in the colon, you're going to say you have Crohn's colitis or ulcerative colitis or whatever. So this is the study that looked at doctors' letters to patients, and they looked at how they described the diagnosis as clear or qualified. And you see what the adjectives are. Next slide. 2/3 of the patients with functional diagnosis were given qualified diagnosis. 87% with organic were given clear diagnoses. And the reason goes back to the dualistic model. If you find ulceration or you find pancreatitis, you say that's what you have. But even though they might meet Rome criteria, I've had a negative study and have had it for 10 years. You just can't say you have IBS. Instead of you may have IBS. So that's the point. That's why Rome is pushing so hard use of criteria and the evidence that an adequate workup meeting criteria is 99% long-term evidence of when they followed for a year or two. And this is also associated with more procedures in the functional GI patients because of the question needing to be reassured. We had a patient today who probably didn't need any more procedures, was inpatient. And I asked, is there anything that you're looking for? And he said, no, we really don't expect we're getting a cal protected. And then he said, well, at least I could practice some. But the recognition hit that this probably wasn't necessary. And that's what happens. You do it sometimes for reassurance for yourself, for the patient. Next slide. Okay, let's look at this video. You can take notes if you want. It's an old video. It's only about 2.5 minutes. Let's see what elements you're seeing. How can I help you?
Well, when I came back from vacation, I got a flare-up of whatever it is I have. Nausea, diarrhea, fatigue, and stomach pain. So Dr. Jones said I should come
Was
see
this
you.
something like you've had before?
Well, yes, but it's never been this bad.
Is it made worse by food?
No. Well, maybe, but I don't eat much when it gets bad. Do you think it's something I ate?
I don't know yet. Did you have diarrhea or fever?
I think so, but I didn't take my temperature.
So you have diarrhea and fever?
No, I get constipation too, but that's normally when I'm not eating well. And I know some diets could help, but and it's important to eat regular meals, right? I do know that if I eat fatty foods, I get pain and I feel queasy right in here. Doctor, I'm really worried about this.
I'm sorry, I'm not quite following. What type of bowel problems did you say you were having?
Normally I get constipation, but when it's really bad, I have diarrhea too.
This is not going too well. Can you see some reasons why? Okay, I want to do a physical exam and then maybe we can talk more about the plans. That be okay? Nonverbals. Well, everything seems okay. What I'd like to do is a blood test for celiac disease, and then I'd also like to do a colonoscopy. No, it'll probably be okay. This way we'll be sure there's really nothing to worry about. So don't worry.
Doctor, what is it that I have? You know, I've been reading online about patients that have the same symptoms that I do, and they call it irritable bowel syndrome. Is that what I have?
Perhaps, but I think we first need to rule out anything organic.
What's organic?
I mean, something specific that we can treat. If the studies are negative, then what I'd like to do is put you on an antidepressant, and that will make you feel more comfortable with your symptoms.
Doctor, I'm not depressed. I just can't deal with this
No,
pain.
I'm sorry, I didn't say you were depressed. These medications can help your symptoms. Look, let's just see what the tests show, and then we can take it from there, okay? Okay, we're going to show another one done a little bit better. But what if, I should have asked for a flip chart, but we can just do it this way. What are the elements?
We got a board back there.
Okay.
We have, dark biogenesis.
Erase it or just work here?
If you just work here.
Yeah, I'll work
I don't know if it's that long.
Okay. What kinds of things struck you?
You really were making eye contact with the patient. And it seemed like the physician had an agenda and a checklist of things that he wanted to, rather than really listening to the patient.
You felt the patient unnoticed.
The patient had a lot to say, but the physician had certain things in mind that wanted to fit into some framework, I guess,
So not actively listening.
not actually.
See, these are the things we've been covering. It's easier now to come up with them.
Not validating the patient's concern that this was very difficult and she was very concerned about what she was having. So not validating her.
No
concerns.
validation. Is that right?
Not answering her questions. I think the patient had questions along the way. And I think the doctor was trying to get through reporting various elements of the history, but didn't really address the questions that were asked.
Doctor had his own agenda, right? This is the active listening part. He was waiting to get this way. Doctor on agenda and thereby ignored hers.
Hi, could I add one more? This is Andres from offline. In terms of the active listening, I think there were key pieces of information the patient was providing, like what she was eating, that could have been leads to very good questions in the history, but the doctor had his own set of questions he wanted answered first, and I felt that was a missed opportunity.
Yeah, there was a narrow focus.
Yeah. I mean,
In fact, which wasn't achieved. She's talking about diet, and what does he say? Do you remember what he said to her? So let me understand, is this diarrhea or constipation? Right, he's still focused on trying to figure that out.
Mhm. It was so bad. I was laughing because it was so bad.
I think also the patient was clearly suggesting that she may have IBS, but the doctor was not providing more information or taking that opportunity to educate the patient of what she may be experiencing.
She read about IBS, but worse than that, what did he say?
That maybe.
Huh?
That we need
Too loud. We need to do some organic.
other things out.
First, we have to see if there's something wrong, which is invalidating the diagnosis. Patients with IBD can have IBS, right? There are criteria for it. So what he was doing is he was diminishing that information. by saying we want to, in a dualistic way, this is not real. Let's find something that's real. Let's do some more studies. So he was invalidating. How about treatment?
To say antidepressant with no introduction to that, it was premature.
Right, and this is again why Rome has changed it to just neuromodulators, which is easier pathway.
Yeah, and with no introduction into what's the reason for that treatment.
Right. Right. Okay, let's look at the second video, and it's just about the same amount of time, maybe a few seconds longer. Oh, here you go. How can I help you?
Well, when I came back from vacation, I got a flare up of whatever it is I have, nausea, diarrhea, fatigue, and stomach pain. So Dr. Jones said I should come
Was
see
this
you.
something like you've had before?
Well,
Is that the exact video?
Oh, is that the same one?
Yeah.
I think it's the same.
I think it's the same one, you just have to continue.
Oh,
It's effective.
yeah, this one.
Hi, Miss Simpson.
Hi.
I'm Dr. Drossman. How can I help you?
well, I came back from vacation and I got a flare up of whatever it is I have. Stomach pain, nausea, diarrhea, fatigue. I just got this new promotion at work to floor supervisor, and then all this happened. It started with the muscle ache and fatigue, and then I started getting queasy and having pain. It was worse after I ate. It was kind of like a stomach virus. You know, I felt warm. I didn't take my temperature, so I don't know, but it was just definitely getting worse. I went to see Dr. Jones and I asked him what he could do to help me, and he thought I should come see you.
Tell me more about the symptoms, like what makes it better or worse?
Well, it's definitely better after a bowel movement, and it's worse after I eat or when I'm upset. I'm really starting to worry about this.
I see.
I don't feel like I can go work out or go out to eat. And I just got this job and I'm just worried, what if I can't do it? And at home, I just don't feel like I'm doing a good job there either. My kids are great, you know, they help out and all, but I just don't know.
I can really see how this is affecting your life.
Sometimes I feel like no one understands.
It's got to be hard when people don't really understand what you're going through. So what do you think is going on?
I don't know. I have been reading on the internet, and it seems that there are other people that have these same symptoms, and they call it irritable bowel syndrome.
Yes, irritable bowel is a possibility. And if that's what you have, I want to make sure you get the right information. You know, there's a lot of research going on now to help find better ways to treat that condition. So these are one of the things we'd be thinking about. We want to try to do some other tests, and then we can take it from there.
Okay.
Well, this has certainly been helpful. So what I'd like to do is why don't you get into a gown, and we're going to go ahead and do a physical exam, and then we'll come back and take it from there.
Okay.
Well, you know, I can see that you've had 2 extensive medical evaluations, and between that, the fact that your symptoms haven't changed any, and from our medical evaluation, I do believe you have irritable bowel syndrome. So I think I'd like to work more on managing your symptoms rather than doing other tests that may not be necessary.
So what do we do?
Well, there is no magic pill. I think you know that, but we can work on this. I can see that these symptoms have had more effects than just the pain. It's affected your quality of life, your relationships with others. So while we're working on your symptoms, I'd like to have Dr. Johnson, who's a colleague of mine, a psychologist, who would help you develop coping strategies to help you get back to a more normal lifestyle.
But you'll still see me too, right?
Oh, yes, of course. Dr. Johnson will be part of our healthcare team, and we'll be focusing more on the medical management. And in that regard, you've been on a lot of medicines that haven't been very effective. I'm thinking we might want to get something that might work a little bit better for you. It's a type of antidepressant that helps with pain.
Do you think I'm depressed?
What are your thoughts about that?
Well, maybe because of the symptoms.
Well, medications have different effects. Aspirin, for example, can be used to treat pain, but it also can prevent a heart attack. And just like that, the antidepressants, in addition to treating depression, can actually act as pain modulators. They can block pain signals going from the gut to the brain. And in blocking the pain, it can raise your pain threshold. That's in addition to, if you are having any depressive symptoms, it could help that as well. But whatever we decide, we'll be working together on this to modulate your symptoms and getting you to a better place.
Okay, well, I'll give it a try. Thanks, doctor.
What was different? Just the first 30.
I mean, even though you were on the computer, you were kind of nodding along and I don't really listen. And the first part was just listening, which I thought was good.
Was I on the computer all the time?
Well, no, I mean, you were on the computer, but sitting by the computer, but you weren't typing all the time. You were actually nodding along.
But one of the elements that we talked about yesterday is when it was an affectively laden discussion, I stopped, I turned around and I faced the patient.
You made
So that was when she was talking about the difficulties. So if I'm taking data, that's okay, but then I stopped when it became emotional. So let's just say, I'll just say computer. You know, what else?
You greeted the patient and you introduced yourself.
Such simple thing.
You used empathetic statements like, I hear this is difficult for you.
So this is really affecting your life. I believe, I don't think anyone understands what I'm going through. It must be difficult when you don't feel, so what you're creating what's called a nexus or a bridge. And again, put yourself in the position of the patient. If you are the patient and someone says that to you, that's very different than, well, how many times do you have about it? It's a different kind of context. What else?
I liked when she said, "Do you think I have depression?" And then you said, "What do you think?" So I think that there was some like nice reassurance, but also getting her agenda.
These are the statements that patients make where you can be trapped if you think dualistically. Do you think I'm crazy? Why do I really need an antidepressant? If you say yes, you're damned. If you say no, you're damned. So you say, what do you think? Or you might say, I wonder why you're asking that. Well, Dr. Jones told me that he thought I was crazy. So you're worried that I think you're crazy. Is that what it is? Well, what do you think? This is the way you create the dialogue to bypass this kind of catch-22 situation. What else?
Along those lines, your questions were open-ended.
More open-ended.
Also asking the patient what does she think she has.
Yeah, so it's her, that was the second item on our list. What does she have? And how did I say what she had?
I think
That you were confident in your
Yeah, I said, well, we looked at all the studies based on the exam. I do believe you have irritable bowel. So I don't want to do any more tests. Let's focus on treatment.
So Doug, I have a question about that word belief, because belief, it's like, well, you believe that, but what do I really have? So, because I think belief can be a challenging word. Some people interpret belief differently. So So is it an okay word to use, or would you?
Well, that was a role play. I mean, I guess I could also have said the studies, from all the studies you have heard about, I could do it that way too. But you're right, it may sound more qualifying to some people. But I also said that the studies are not showing anything else and we need to move on and treat it. So, yeah, I think it's reasonable. These are all role plays out there, not scripted. How about the implementation?
Oh, it's like showing, explaining with the diagram was really helpful.
Giving them a physiologic understanding of what you're doing. You see that better in some of the other. This was an old video. This was about 10 years old. That's Cecile Rooker, who's worked with me in the Rome Foundation. Now she's president of our
I really like your aspirin analogy.
try to make analogies that are relevant to the patient. And we're going to get into that when we look at one of the videos about things you can say when you want to. Okay, so the body language was facilitative, as we talked about. The interview was facilitative. She could tell her story. There was more silence. You know the story. 12 seconds is when doctors interrupt after the opening question. 12 seconds. So you want to give them more time. Education was a dialogue. IBS was affirmed. And then we talked about the rationale. And then I said we would continue to work together. The patients don't want to be abandoned. If they know they have a follow-up appointment, they're less likely to call an emergency problem as well. Okay, next slide. So now we're going to go into Communication 101.5, which there's a series of videos. 101 is where we take our key leaders in GI who talk about basic things like how do you explain a FODMAP diet? How do you explain Linzess? How do you refer to a psychologist? So those are straight. 101.5 are more challenging, where there are issues that we get confronted with and how do we extricate ourselves from the situation. And 202 is more advanced. If we have time, we can play one of those, which is a deeper dive into the more subconscious elements of what's going on. But this one, I think, is good because it talks about the patient who wants more tests when you don't think they're necessary. Okay, Ms. Simpson, the studies are negative, and you have had a lot of studies before. I'm pretty satisfied that you have IBS, and we're going to look at some treatment options. Would that be okay with you?
Yeah, I mean, I definitely want to move into managing this IBS that I have, but I am a little bit I just want to make sure we've really ruled out everything else. Like you're certain that that's what I have is IBS.
Well, from the studies you've had, they've been negative. You fulfill criteria for IBS. And I think it's time now to start focusing on management and not doing more tests.
Well, there's one more test that I haven't had yet, and I was hoping maybe we could do that first before we settle on the diagnosis. I really think that I need to just have one final scan, maybe a CT scan, and just make sure that there's nothing else going on that maybe the blood work and the colonoscopy might have missed.
Well, you actually had a CT scan about 2 years ago, which was negative.
Yeah, no, I know, but I mean, that was 2 years ago, and stuff can happen in 2 years. I mean, you read about it all the time. People suddenly have this, tumor that appears or something's going on. And I just really want to make sure that there's nothing else. I mean, my pain has gotten so bad over the course of the 2 years. And
Yeah. How bad has the pain been?
I would say it's a 10 on a 10 scale. I mean, it's pretty bad. It's impacted every aspect of my life. And I just, I don't know if I mentioned it to you earlier, but I do have a family history of pain like this. And it just, it concerns me that maybe it's something more serious than IBS. I mean, I just want to make sure we're not missing something.
So how much is this really affecting your life?
It's affecting it a lot. I mean, it affects my kids. They're wondering why I can't do the things I used to do and why I'm always anxious and worried. I mean, it's just it's a big problem.
So it's really important that you get this resolved.
Yeah.
But I know that you've had a lot of studies. I'm wondering, why is it that it's so important for us to keep getting studies rather than focusing on the diagnosis you have and the management?
Yeah. Well, I mean, I don't think I mentioned it to you earlier, Dr. Drossman, but my mother died from pancreatic cancer. And she, early on, before she was diagnosed, this was a similar sort of pain that she had. And nobody really figured it out until it was too late. And I'm just thinking, I'm 45. It could be a hereditary thing. And if I just had one more scan just to make sure that everything's okay, then I would feel better. I would feel more reassured.
Yeah, I guess I can understand why you're worried about it. But the situation is different because you have been evaluated before. In fact, you had a CT scan about 2 years ago. What if we were to do another CT scan? Would you be satisfied?
Yeah, absolutely. Yeah.
And how long would you be satisfied for?
I mean, I don't know, maybe a couple of months. I don't know.
You see, we do these studies when we have a reason to do the tests. And in this case, we don't have any real evidence to be doing the test again, since you had a study 2 years ago and you've had 10 years of pain
Yeah.
and IBS. So we don't expect there to be any difference. Let me suggest this. What if we were to begin treatment and we have all reason to think you'd be getting better? If you got 25% better, would you still be concerned about something being missed?
No, definitely not. I would feel a lot more reassured.
Okay, let's do that. And I can assure you that we'll stay vigilant. If anything new develops,
Okay.
we'll be glad to do other tests if something comes up that demands that it be done.
Yeah.
Okay.
Okay. All right. That sounds good.
All right. We have a plan then.
All right. Thanks.
Okay. What happened here?
The negotiation.
Hmm?
The negotiation.
But the negotiation has to be done at the right time.
Mhm.
In the beginning, I said you had a CT 2 years ago and it was normal and she cut right in. And why did that happen? Why didn't it work in the beginning where it worked later?
CT was her agenda and she wanted to, she's thinking of my mom got diagnosed with pancreatic cancer. What if this is pancreatic cancer and it's been 2 years, nobody's done another scan, so.
Right. So the unspoken issue was that her mother had pancreatic cancer. She was afraid that she might have it. And it was only 2 years ago. And so she was dualistic in her thinking. She wasn't listening to what I was saying. She wasn't prepared to listen. Then later, after I said, what if you do this? And then she disclosed about her mother. And then she said, can we do just one more? And when I said, okay, but for how long? I put her in a position of having to think about this differently. And she went to what's called the pre-contemplative, where she's beginning to be open to other possibilities. At that time, she's receptive to what I have to say. So when you're working with a patient, there's a dynamic process of, is the patient receptive to what you're saying and are they not? And at that point, I can then explain what I'm doing and why, which then allows me to bring in the next element, was the negotiation. If we can get you 25% better, would you be satisfied? If I said that in the beginning, she wouldn't be satisfied. It's just that kind of dance you have to kind of go to bring to that point. So I think this is a good example of that. Trying to bring them to a position of stepping out of themselves and seeing how others can see it and approach it. And the end part was, and if anything changes, we'll work it up. You don't want to say this is what we're doing. So the next slide. Okay, So in the beginning, there was a lack of consensus, dualistic thinking. And then I asked her, when she's kept asking for the test, I kind of changed the agenda and asked her how she's doing, what's the impact on your life, which gets her into a more personal space rather than a dialogue about, oh, we're going to do the test. You retreat back and you get into another area of her life. And then I was empathic, which then makes a bridge. And then I challenged the logic of the CT. And then I was able to successfully reaffirm the negative word. Okay. All right. Should we look at another one? So let's see what we have. So I want you to pick the ones you're most interested in. Can we go to my slide?
Yeah, I think it should be able to.
Okay, so excluding cancer. Well, Scott, we just finished the workup.
Yep.
I do want to
Well,
do a
Ms.
few
Simpson,
tests.
your physical
Okay.
exam
We're
was
gonna
normal,
do a colon
except for that
last week.
abdominal discomfort you had, much like several months ago. It's not changed.
You want to take a
Your
break?
blood
for 5
studies are
minutes?
negative, and I know you're having some continued
5-minute
pain,
break.
so maybe we should talk a little bit about putting.
See, where it's water time.
Okay.
But it does sound like
What happened is not appointed. That's why they get us.
Or expand the PowerPoint.
I want to expand the PowerPoint so I can see all the slides on the screen.
Yes, I'll be there.
Oh, here it is. Okay, now expand the whole thing.
That's what I'm doing.
So anyone use a map, you know how to make this screens?
Because it's just one presenting, so you would ask you, so when I got so why? Okay. Oh, okay, nice. I have to research research.
Roll up.
And then they have and then just do the poster rash.
Okay, so what happens? Everybody see.
Yeah.
And then I guess we could just.
Yeah, catch up with people.
Yes, yes, yes. No, I'm excited. Actually, better this as it did at the same time, but.
Sean was asking if I see them.
Maybe
It's an incredible and non-incredible.
Weren't you asking me to see them?
Yeah, yeah. Oh, you have a SIBO.
Yes.
Yeah, I would love to hear
Okay,
that.
what do we do this? What do we do this?
Isn't that incredible? You see them? Okay. Nielsen wants to do this.
The teenager.
Yeah.
What do we do? The teenager. And then follow that with the.
Okay.
So that would.
And then non-incredible.
She's supposed to listen to these two.
Yeah.
There are something my first time.
Yeah, that's right.
Yeah.
I don't know.
Well, it's
It's 100 feet.
really.
What do you think about doing 202?
She was.
She comes in with a really malleable stare. And then she's bed
But it's funny. Because she's
we have others.
But it's.
Okay, we're gonna go ahead and get started again.
So this is for Nielsen.
You'll see this one's for you.
Oh.
Okay. This is my patient from days ago.
Maybe we should do it that way.
Oh, there it is. I just forgot.
All right, so this is. So hello, Nancy. I'm Dr. Drossman. Ms. Simpson, nice to meet you both.
You
And
too. Thank you
my
for
nurse
seeing us
practitioner.
today.
Okay, well, how can I help you, Nancy?
So for the past couple years, I've been having abdominal
go back
pain and
and
bloating,
make it louder?
and it's becoming to a point where it's getting worse, and I'm
Uh-huh.
about to go to college, and I'm here today to see if you can help me. But it's not just that, right? I'm sorry to interrupt you, but
Yeah.
Dr. Drossman, it's more than that. I mean, she's being too tough. She's not even
Let's-
telling you how sick she's really.
It's just so true.
Hello, Nancy. I'm Dr. Drossman. Ms. Simpson, nice to meet you both.
You too. Thank you for seeing us today.
Okay, well, how can I help you, Nancy?
So for the past couple years, I've been having abdominal pain and bloating, and it's becoming to a point where it's getting worse, and I'm
Uh-huh.
about to go to college, and I'm here today to see if you can help me. But it's not just that, right? I'm sorry to interrupt you, but
Yeah.
Dr. Drossman, it's more than that. I mean, she's being too tough. She's not even telling you how sick she's really been. Like, she has very bad abdominal pains. She has diarrhea some days, constipation other days, right?
Yeah.
And she, like, it's gotten, you're not even eating like you should be.
I
mean,
am somewhat.
Well, why don't you tell me
Yeah.
how it's affecting your life?
Well, I can't go out all the time now. I'm always at home in pain and
and I think she might have to just stay home with us. I mean, she can barely go to class.
If it's
And
all right,
so,
finish what you were saying, please.
so like I said, I'm always at home and I'm not doing much. I'm not exercising. I'm not going out with my friends to eat. I'm on a
she's-
limited diet.
Yeah.
And
and look,
yeah,
she's
it's
like lost
miserable.
like what, 7 pounds, 8 pounds so far?
Not quite.
She's like wasting away.
So she says you lost 7 pounds. What do you think?
I mean, I lost probably up to 5 pounds, but it just waxes and wanes. Some days I gain it back and some days I don't. So it just really depends. My mom exaggerates things a bit sometimes.
I got her a sweater in her
Yeah.
normal size and it hangs on her.
All right, why don't we get back to the history?
Mhm.
Tell me more about how it's affecting things for you right now.
So I'm going to be starting school next semester. So I'm constantly in bed and I'm not doing much and I'm not eating much. And
it's just impacting my life. I'm hoping to even start a part-time job during this time.
And you're going to school away from home right now?
Yes.
Okay.
Yes.
Which is my mom's very concerned about.
I am because I'm not there. I mean, I call her every day. She's telling me she's in bed, that she didn't go to her morning classes because her stomach was hurting too badly, that she's not eating. We pay for the meal plan and I see that she's not going to the cafeteria. She's not logging in her card. So I know she's not eating because that's the only place she would be able to eat. I'm very concerned that it's getting out of control. She was trying to manage it on her own
I'm
with over the
fine.
counter. It's not working. It's not working.
I don't know. I think you're exaggerating, Mom, at times.
If it's okay, Ms. Simpson, I want to try to take more from your story from your daughter.
Of course, I'm just trying to add some context because she doesn't always give all of the details. And
You know, I'm sure that this is affecting both of you. How is it affecting you with her?
well, I'm very concerned about her. I mean, she's my only daughter. We adopted her from China when she was 3. She's always been very special to me, and I'm just so concerned that I can't be there when she's not feeling well.
I'm fine. I'll be
What
okay.
worries you the most about this?
that it's going to spiral out of control, that she's going to end up in the hospital without me, that she's going to end up with an eating disorder because she's not eating appropriately to when her stomach hurts, and she's going to lose all of this weight, and it's going to be just something that we just can't get back into control. And that's really, she has such a bright future. She's so
I know you're
smart,
concerned
and
about
I
me,
just,
but
she has to
I know.
continue to be able to be okay.
I mean, it's hard for Nancy, it's hard for you too.
Yeah. So what can we do?
Well, I think we have ways to treat this. I think what I want to do now is talk to you some more.
Okay.
And both of you can participate, but I really want to hear your side of the story.
Okay.
And we'll focus on that. Then we'll do a physical exam. And then what I'd like to do, if it's okay, is to see you one-on-one to talk a little bit more. I mean, you're an adult now.
Dr. Drossman, I don't really think that's going to be helpful. I have a lot of perspective as her mom, and I really think it would be better. I mean, this is the first time that you're seeing a specialist by yourself.
Nancy, how do you
there's
feel
gonna
about
be-
that?
I guess it's okay.
I think we'll go ahead and talk, and then we'll all get together and we'll summarize things.
Okay. I mean, but I'll be just right outside the door. So
Okay.
if you need anything, just tell her. If she gets uncomfortable, I'll just be right there.
Thank
I
you.
know her well-being is important to you
Yeah.
too.
Okay.
So sorry.
What did you see here?
Overly concerned mother. We have lots of those on the inpatient side. But they're not teenagers. No, they're adults. Yeah. They're adults.
I like what you said about validating the mom's concerns. You're clearly concerned with your daughter's well-being, very caring. It's affecting you both. So I think bringing her in and then shifting nicely to the daughter. What is your experience?
Yeah, so the dynamic here to start is the mother is here trying to control everything, and the daughter's pushed down, not able to speak. And if I were to be confrontative and start focusing on the daughter, the mother would get upset. But if I could bridge that by validating the mother's concerns, that makes her a little bit more flexible. Okay, what else?
Being able to separate is important because sometimes you can get a history with parents or if the parent is in the room. So that was a very tactful way of doing it.
I had to get to the point where we would separate them. Right. So that would be the second item. And usually what I do when I have an adolescent is I'll keep the family in, do a history and physical, and then when the patient's ready, dressed, I come back in and speak to the adolescent. And then we bring the mother in. Now that's data. If the mother like her says, oh, you can't do that, then that's data. We know that there's a level of enmeshment there. But if they say, okay, then we know it's a pretty healthy relationship. The mother's concerned, but not enmeshed in a relationship. So that's something that we can learn. And so that was the next step. What else did we do? Why is this happening? What are the dynamic elements?
Daughter is going away for college and mom is concerned that she's not gonna be with her.
What's going away from college?
It's interesting because the daughter's also validating the mom, like she's the patient, yet it seems like the mom is more upset than the patient.
She's trying to reassure the mother. Going away to college is one thing. Adopted from China, which creates a different dynamic in the way she's got a lot of sense of purpose, guilt, whatever you want to say, to try to make it right. So that was another factor that could be leading to this. And then, of course, in the end, we end up letting her know that we'll continue work.
I think, so I'm, just, relatively new, to this, but one thing that I haven't seen too many of these, kind of, parental, child visits, but one thing that differentiates this one from some of the ones that I've seen is that, and that I think did give a bit more of a pathway to you as the doctor in it, is that the patient seemed to have, the daughter seemed to have a bit more kind of insight into what was going on, and still seemed to have some sense of kind of autonomy and her own identity. And when I, in the small sample of these types of visits that I have participated, it hasn't been that like it can either be that the typical daughter is completely like subsumed by the mother, or just has fed into this concern, so like has received the anxiety and absorbed it. And I think that it's a little harder in that situation, and I think that seeing, just from before I came here, any kind of, like, if you were in the emergency room and there was like a parent and a child who came in with some sort of a psychiatric complaint, you would see them individually. So I think that's really helpful, but it's also kind of harder to do with the telehealth and stuff. And so I'm just wondering if you've any thoughts on how, in something where there was a little bit less like possibly predisposition to or where it's a little more difficult, how you would approach it.
Well, I think what we're talking about is the level of individuation, separation of the daughter, that she's evolved to a point where this could occur pretty successfully. Then you have somewhat suppressed and meshed, where the family situation may have been so consuming and so that the child has not individuated. We see that, and that's much harder because you can't separate. Of course, if you ask the daughter alone, she'll say, "Oh, whatever my mother says," essentially, and that's a much harder thing. I don't have a good answer to that, except to work with them, and maybe in a therapeutic situation, the mother would have to address the fact of her need to kind of give up the child and give her some autonomy. But the child is not a willing partner in that just yet. So that's a part of the transition which might occur. We tried to make this where you could do something.
Right, sure.
Let's do the credibility. I think that's for a bit of on this. These are all actually patients, okay? This one I'm still troubled is we still have here it is. All right, so this is an actual patient who I've seen, and it's still struggling. Ms. Byers, how can I help you?
Hi, Dr. Drossman. So thank you for seeing me, by the way. I know that you are a really busy physician, and I'm here because I've been seeing several different doctors, functional doctors, and I am just, well, I mean, I brought my records for you. I'm just a mess. I have so many things going on. And frankly, it's really overwhelming, and I don't know what else to do. They recommended that I see you because you deal with really complicated patients, and I guess as you can see from my file, I'm fairly complicated.
Well, tell me a little bit about what you have, what symptoms you're having. And
oh my gosh. Okay, so maybe about 8 years ago, I started with all of these symptoms, which were basically episodes of diarrhea and nausea and vomiting when it gets really bad, abdominal pain, bloating, distension, belching, just like all the gastro kind of symptoms.
so you said
And
episodes?
yes, so they're kind of episodic in that I'll have everything will just kind of come on at one time, and it gets worse and worse and worse, and it just kind of lasts for maybe a week, 2 weeks, and then they kind of quells back down again, and then I'm doing okay, it's manageable, and then for whatever reason it flares back up again. And you know, in the past I've been able to just kind of like get it back under control, but lately that hasn't been the case. It just flares and it never goes away. So that's why I'm just really trying to figure out what's going on.
So if I understand right, you started out years ago with having this for a brief period of time,
Right.
and then you're okay. And then now over the years, it's become much more constant with flare-ups.
Yeah.
Okay.
Yeah. Yeah. And when it's really bad, I'm vomiting, and like it's just really dreadful.
And I see from the record that you've had a colonoscopy, a CT scan,
Right.
upper endoscopy.
Yeah.
All of those are negative.
They are. But I mean, that is just the tip of the iceberg. I mean, I've been seeing functional doctors because frankly, I feel like they're more in tune with the human body. They can find things that regular doctors kind of don't seem to think are a problem. And God, I have so many issues. I have Lyme disease. That's come back now. I have mast cell activation disease that's also going on with me. I have Borrelia, I have angioedema, I have the last doctor told me that I have gastroparesis. Next week, I'm going down to the lab to give a urine sample to test for porphyria because of the abdominal pain that I have that's just so bad. I have just all sorts of parasites going on. I mean, I'm just like, I mean, you can see everything right in my chart.
And how are they all treating you?
Well, I mean, so I've done a whole series of herbal treatments. I've done some oral herbals in teas and capsules. I've also had some suppository type treatments that are all natural to try and kill the parasites. And then I've had some other treatments, oral medications like for the Lyme disease and whatever. And then the last thing is I've done this great test. It's this like machine, and you put your hands in it, and it scans the body's homeostasis so that it can tell if some of the medicines are working or not. It looks at your body chemistry, and it kind of tells you what you should be doing. And interestingly, you know, my primary care doctor had me on Cymbalta, thinking that might help some of the pain that I was having. But this machine showed that actually was detrimental, and I shouldn't be taking that. So I'm not taking that anymore, clearly. So all that to say, everything is in here. I don't really know what to do. I mean, clearly the treatments that I've been trying are not working because I'm still symptomatic. And, like I said, the episodes aren't resolving like they used to. I don't know what is going on. I'm a mess.
Yeah, it sounds very scary what's going
It
on.
is scary.
I've looked at your records. There are actually
Yeah.
several hundred pages of them.
I know.
And,
8 years.
and a lot of the tests that were done are not well documented in my mind. And I'm wondering, what are your expectations from me after you've been to all these doctors? What do you think I could do that would be helpful?
Well, I guess I thought maybe you might have some sort of idea. I mean, Dr. Johnson said that you treat patients like me who have Lyme disease and, parasitic illnesses. And so I'm just hoping that maybe you have an answer of maybe a miracle drug that I haven't tried yet or haven't heard of. I mean, I just can't keep living with all of these.
And how much do you believe you have these infections going on?
Well, I've seen the results of the testing they've done. I mean, they've done stool samples, then they've showed me like under a microscope. Like I've literally seen like the little parasites.
That's right. They do show you that. But what would you say if I were to tell you that there's really no evidence for that the tests that we're looking at are not accurate? Even the laboratories that are doing them are not accurate. How would you feel about that?
I don't know that I agree with that, Dr. Drossman. I mean, I've seen it with my own eyes.
So we have a dilemma. The dilemma is that I am prepared to work with you, but you have many other doctors telling you different things.
Yeah.
In fact, one of the doctors told you to reduce a medication that we might find helpful to you.
Well, that's because it was poisoning me. I mean,
Right. So we're going to have to make a decision whether you're prepared to work with me and not work with the other doctors. In other words, give the opportunity for us to treat you based on what you have. We have more of a history to take, need to do a physical exam. We may do some other tests, but what we're looking at, it sounds like you've got a disorder of gut-brain interaction, chronic pain, IBS symptoms, and those have treatments which you haven't had yet. Can you suspend the judgments you've gotten from the other doctors and work with me, and then give it some time and let's see what goes? Because you're on medications that could even be harmful. Your anti-parasite drugs. It also said you had mold. It said you had Borrelia.
Yeah.
Too many diseases.
I know. I
Ms.
mean, I've
Byers.
moved 3 times thinking it was maybe the environmental issues or, I don't know what else to do.
What you'd have to do is to suspend these other treatments and work with me, and then we'll see how things go.
Okay, but one thing is that I am being treated for SIBO. And Dr. Johnson has me on a cycle of antibiotics. So I do need to finish that. I have another week left of that before we would start anything else. Because I did the breath test, it was positive. So I need to finish that.
And when does that end?
So I have 1 week left.
Yeah. I won't object to you finishing it for the week. I don't think it's going to be valuable because you've been treated for it before. But please go ahead and finish it. And at that point, we need an understanding that you'll work with me and not work with the other doctors.
Okay. Yeah, I think let's give it a shot and see how it goes.
Okay. Catastrophizing usually implies that they're feeling hopeless. And, we can put it down as a kind of catastrophe.
Doctor shopping.
Doctor shopping.
She wanted a miracle drug.
Searching for a miracle drug.
There's a distrust, right? She says you guys don't believe me, or no doctors figure it out, the natural, what did you call that? The other function. The functional doctors, they believe her and they are in tune with her. So she
Regular
believes-
doctor.
Regular doctor, she doesn't trust them.
One of the elements you see here, and the question I asked the patients, I didn't do it in this video, she's on all these treatments. And I say, well, how are you doing with them? No better. So you can bring in the credibility of, if you're taking all those medicines and you know better, shouldn't we look at other options? That's another segue that you can bring the patient. But there's this, it's like gluten, it's the retention. People retain themselves on gluten-free diet, even though they're still having the same symptoms, right? Okay. What else?
It seems to me that she, even though she ostensibly comes in looking for a miracle drug and another opinion and help, she actually kind of attaches to being a complicated patient, and it's part of her identity that is actually something that she almost values or like isn't kind of a negative that she wants to dissociate from.
Yeah, I'm a very special patient, and it becomes a kind of a lifestyle. Patient that I'm seeing now, she did give up the other doctors, but she comes to us to keep trying to find new things that she wants us to change medications and do this and do that. She doesn't engage. I think that's one of the critical elements here. She really doesn't engage with the doctor. And so if you don't engage, you don't have that ability to communicate. So I'm always being put in the position of having to respond to her requests, which don't go anywhere. I co-managed her with a psychiatrist, and after a year, he came up.
So Doug, what do you do in that situation? Because I see this a lot where patients will, they come to you, you make suggestions, they dismiss all the suggestions, but then they come back, and then they keep coming back, and they don't engage in anything that you've recommended. And just like your patient, they keep, proposing other things to do. So you've never been in sync with this individual, but yet two plus more years go by, and they're continuing this, like, being a struggle with you. How do you disengage from that type of relationship that's not going anywhere, or how do you get them to engage?
Yeah, so I think it depends on what level of insight they might have. So one way to do that, if you remember at a workshop we talked about here and now, I might address to the patient, how do you think this is going? We talk about what's going on now between us, and use that as a gauge. And what you might bring up is, it doesn't sound like this is going well with you, and it doesn't sound it's going well with me, because I'm feeling frustrated. And you become very human to the person, and you see if we can come up with some resolution about this. That's one way you could go. I mean, and it may be you'll be slammed down completely, and they'll say, well, because you haven't found the right medication for me. Or she might step back and say, can we look at this a little bit differently? Which would be planning some protocol and treatment together, and not making you the one to provide all the answers. So that's a hard. I mean, obviously, position you're in, you're going to get the hardest ones, just like I.
Something interesting that I've kind of noticed with this video and the last video, and that's come up a lot, is this idea of like boundary setting. So, getting her to commit, setting that boundary of, you need to stop seeing these other providers if we're going to work together. And just curious if you have other approaches or advice around setting boundaries with patients. And for example, on the inpatient side, like patients will be like, well, this doctor told me I like need this medication. I think that comes up a lot of patients wanting to take control of their treatment plan. We talked about, okay, they need to be involved, but how do you balance that?
So will give me a scenario. Give me an example.
Or I'll let one of knows it than the inpatient.
Well, on the inpatient, we had a situation where there was a patient who was wanted more narcotics. And she actually said, well, Dr. Goldenberg said, blah, blah, blah. So I actually approached that. And then we talked, and then I said to her, well, we talked, and I think there was a misunderstanding. This is fun. So that's how I approached that one. But sometimes in our inpatient service, the patients often say, well, this is what this other doctor told me, now you're going against it.
So this is a complicated dynamic because of the system as well. After talking to Morgan as well, that this morning, that in the inpatient service, you're in a position where you're only there for a week. It's another person treating. And so the only way I could see doing that is to get back to the treating physician and come up with a consensus and then go back to the patient. That's a way to, well, it is setting boundaries in a sense, and I'm not going to do what you're asking me to do. We're going to do this by an agreement. But the consensus with the patient is even harder because you don't have a way out. Like at UNC, we would put them into detoxification. You don't have that option here, at least it doesn't sound that way. So you do have to try to promote the idea that this is not the answer to your problem. In fact, there's evidence, there's evidence that opioids can make your pain worse. And is that what you want to do? Or do you want to look at alternatives? And what if we were to put you on medication to treat the pain? And if things are getting better, then we can maybe talk about the something. I think I have on. So I know that's the boundary issue, but it's is that what you were referring to, or something?
Oh, I was just hoping to get like kind of setting that up to see if there were other examples that people had they wanted to discuss.
Are there other ones you want to discuss? Because we can do some.
How do you, I mean, to go back to this for the video a little bit, how do you deal with a patient that is focused on a diagnosis which may not exist?
Like this.
Yeah, like, so what do you, how do you, another doctor told them that they, or some healthcare, somebody told them that they have chronic Lyme disease, for example, and and say you don't agree with that diagnosis. How do you navigate that?
Try to be as factual as possible. You have an IgG, you may have an exposure 10 years ago, but you have no active evidence of Lyme disease now. And I think what's going on now is you've been given that diagnosis as the answer. In my opinion, you have chronic abdominal pain, and we have to deal with the nerves that have been altered. I try to give an alternative explanation.
And do you find that addressing it head on changes your relationship with the patient?
Depends on your relationship with the patient. So in that situation, I guess we could role play it, but you want to be that person?
Sure.
Okay. So why don't you start it? I've seen you in the clinic. You have abdominal pain. You're coming to me, right? For my opinion. And I say that it sounds like you have centrally mediated abdominal pain, and we have some management options for that. What are your thoughts?
So, okay, I'm not an actor. So, but I did a stool test from my naturopath doctor who analyzed my microbiome, and they found a bacteria that was elevated, and they told me that I needed to be treated.
Well, did they treat you?
They gave me a lot of different medicines, but I haven't started anything yet because I wanted to get your opinion first.
Well, one of the things we're dealing with in this field is that there are a lot of tests that come out that are not falling under proper guidance in terms of standardization. And I can tell you, we get many tests that look at stool, and they don't have any clinical meaning to us. The tests show which bacteria are there, but they don't determine pathology. If they did, we would know it. You could have something like a disease like C. difficile or E. coli, but it's not showing that. It's showing normal bacteria. in various compositions. So to answer your question, I'm not sure what you're telling me that I would be able to treat, but I do have evidence of what we can treat for your chronic pain. What if we were to try working on the treatment of the pain right now? And if the pain gets better, would you still be interested in having more stool testing?
Sure.
This is a question. This is a question that really works. This is a question that really works. You create a scenario. If we were to go this route and you get better, there's a lot of suggestion here. Would you still want to do this? Like the CT scan.
So Doug, going back to your video, so, you know, Johanna agreed to give up these naturopathic doctors. What if she comes back and she had it and she's continuing to, you know, take these supplements, do other body scans? How do you address that kind of scenario where this agreement that you had has now been violated?
I think you need to look at other options because you work. I mean, it shouldn't happen, but sometimes you have to do that because otherwise you're stuck. I mean, what have you gained? You're just trying to treat along with everybody else and going nowhere. The patient has to engage with you. This patient gave up the other doctors, but still doesn't engage. He's still trying to work on the same scenario.
So do we have time for Sean's SIBO scenario?
We'll look at SIBO.
Just ask you, do you ever release a patient from your practice?
No, I haven't.
There might be a question on Zoom. Oh, have you ever fired a patient? And if so, why?
Well, this is one example where I would have if she didn't give up the other doctors. But I haven't fired a patient. Hi, Ms. Jones. I'm Dr. Drossman.
Hi, Dr. Drossman. I'm so pleased to meet you.
How can I help you?
Well, I am seeing you because Dr. Thompson, my primary care physician, recommended that I see a gastroenterologist. I have had a history of SIBO and asked him to help me with the symptoms that I was having, bloating and diarrhea and just abdominal discomfort. And he ordered a breath test, but it came back negative, which frankly makes no sense to me because I have all the telltale signs of SIBO. And he really didn't know what to do when the results were negative. So he sent me to see you. So I sent your nurse all of my records because I wanted to show you that I know that what I'm talking about. I've actually had a positive test a couple of years ago. And I was treated successfully with antibiotics and I was doing fine. And then, you know, now here I am having these symptoms again and the test is negative, which, like I said, makes no sense because I'm struggling with all the same symptoms. So I need you to give me some antibiotics so that we can, you know, just kind of nip this thing in the bud.
Yeah, and I've actually looked at your records and it looks like you've actually been treated several times over the last few years.
Right.
And I understand the first time, which was about 5 years ago, you did very well. Is that right?
I did really well. It resolved the symptoms so quickly. I was so pleased.
For about a year.
Yeah.
Right. As I recall, you had another test done, which was positive, and that didn't go as well. Is that right?
Well, I had to do 2 rounds of antibiotics that time. I guess it was just a little bit more stubborn of a infection that was going on.
And now, after 3 or 4 courses of treatments, the last couple didn't really work very well. You had a test which was negative.
I know. I think that I just, you know, SIBO can be a real booger to treat, as you know, and I just think that I need a stronger antibiotic.
You were put on rifaximin twice,
right?
And then you were put on neomycin, and there was a question of you having methanogens, and that was treated. and then
Yeah.
on Flagyl.
I know.
So what I've seen over the last 5 years is multiple courses of antibiotics,
Mhm.
and now you have a negative test. So I'm really
No,
wondering
but
if,
what else could this be? I mean, it's the same signs, the same symptoms. It's just like textbook SIBO.
yes, you have irritable bowel syndrome, and irritable bowel syndrome, you meet the criteria for it. A good 30 or 40% will respond to antibiotics because they have what we call dysbiosis. You don't even have to have bacterial overgrowth. You can even have a negative study and respond because it's affecting colonic bacteria. But you've had multiple treatments, and I think it's time we had to look elsewhere. There are many other treatments that we can do, and it may be reasonable for us to say, let's move on and come up with a treatment that might be more targeted to what you're doing.
So you don't think this time it's SIBO?
I don't think it's SIBO because your test was negative.
Can't you have a false negative test?
You
I've
can,
heard of that.
yes. And the point is that you don't have to even have positive SIBO to respond to antibiotics. Clinically, you've
Oh,
been placed on antibiotics and it hasn't worked.
yeah.
So from that perspective, what I think we need to do is look at other treatments. And if you're getting better, then we don't have to worry about the SIBO. Would that make sense to you?
Yeah, no, it makes sense. But I am a person that doesn't like, I don't really love the idea of diagnosis by exclusion. I want to know, like, what's the root cause of my symptoms? Because I feel like the cause, then I can prevent it, or then I know that it's not going to come back if it's treated appropriately.
Right. Well, this is the first time I'm seeing you. I want to go ahead and see you and get more of the history and do a physical exam.
Mhm.
And then we'll come back and look at what the reasons are for your symptoms. We're going to talk a little bit later about how these disorders relate to dysregulation of the brain gut axis. And in
Okay.
fact, people with SIBO, the bacterial component can be affecting the brain gut axis as well.
Really?
But there are many other factors that can do that. And I think it's time we moved on and got something that's more targeted to what might be helpful to you.
Okay. Well, I definitely want to treat it. Whatever your recommendations are, I need to be able to move on.
All right, well, let's get started. We'll take more of the history and then we'll come up with a plan.
Okay. All right. That's good. Thank you.
What do you think?
Very familiar conversation. One I've had many times.
So what was I doing? What was the process? What happened?
Active listening. She had her agenda, listened to her agenda, but then were able to kind of refocus and explain to her different scenarios and explain to her based on her history of interactions with the antibiotics and how many times she tried it. We demonstrated to her that this might not be the case right now. You even told her, this time your test was negative, so we're able to use the facts to get her engaged with the visit and further treatment.
Trying to get her, again, dualistic model. This is SIBO, that's what I believe it is. I can't understand why I'm not better, I just need more treatment. To etch away at that with elements of data to the point where she's more open to look at other options. Can't do it in the beginning, you have to go through this dialogue to get to the point where she sees I could provide the evidence that it may not be true that she has. We dissociate her from the belief in the SIBO to open the door to other options. Very common thing we have to do when someone comes in with a fixed idea.
We're at 12 o'clock. I think that's lunch.
Yes, yes.
Lunch here.
Yeah, it's just next door.
And everything. So, and we can we can bring, the room here is bigger, so we could bring lunch in here and then sit around and have a conversation. Any final words for the folks on Zoom?
Them to me, or me to them?
Both, and folks on Zoom, any final questions for Dr. Drossman and Doug? Any final comments for the group?
Hi, this is Andres again. I had a quick question. I'm wondering what are your thoughts and practice regarding contracts, like pain medication contracts and such? Is that part of your practice?
With opioids.
Yes.
I don't set up contracts with, basically, I never prescribe opioids. And when they're on opioids, my effort is to take them off. So I'm not engaging in Suboxone or other kinds of situations. So that's my practice. We were the one who identified narcotic bowel syndrome in 2007. And we know that if you take them off, the pain gets better. And we know that there is absolutely no evidence that narcotics can help any of these conditions chronically. So I stay with that position. And if a patient comes to me, they have to be prepared that they can't either have to be off it or be prepared to come off it. So I don't create contracts. Contracts implies a little bit different scenario.
Okay. Thank you.
The other thing I would say is that these are, what I try to do is, these are learnable elements. These are skills that you can do in the context of your patient care. We have a lot of these tools. Linda has all the videos. We have 101, 105, and 202. Maybe she could do some workshops. You could do the workshops with them in the same way I'm doing. Because just watching it, you can process it. I also think those two books are really good in terms of the elements of the teaching in there. If you go on the Rome website, there's an educational, Johanna and I produced over 100 videos on various GI topics, where we either do it ourselves, like I talked one on pelvic floor disorders and other ones, or we bring in somebody like Bill Che talking about diet, or a pediatrician talking about transition. So can you go to the website? Can you do that?
Doug, you and Johanna were gracious enough to share those videos with me. Can I put this on like our internal website, not website, but our internal drive so that folks can watch? We can talk about that. Or we could do these as
Sessions.
sessions.
I prefer that
Okay.
because we are trying to market. We put a lot of money and time into it, but you could certainly do sessions with that. All right. So there you are. Go to resources. These are all free. And this is the video library. Okay. Now just scroll down. These are videos we've done over the last 3 years on all these topics. And they run about 10 to 20 minutes. Phthalmophrenic dyssynergy. Ronnie Fast talking about the esophageal disorders. It's a great library. We give it to patients, but a lot of the gastroenterologists look at it.
I've watched a bunch of those.
Who is?
I have.
Oh, yeah.
Yeah.
I also share these with patients.
I tried to, I actually tried to, on this same room website, there are these cards you're supposed to be able to download for free, and I've like 10 times I've probably put in my info and it never goes anywhere. I'm not sure if I'm doing something wrong.
How many cards do you need?
I just would like one set so that if I ever patients in person, I could use some of the one.
All right, just email me and I'll forward it.
Okay.
I'll send you.
That'd be great. Thank you.
So there's pediatrics. There's a whole thing on communication skills. So this is good for your own self-learning patients. Now, stigmatization, nonverbal communication, trauma. Go back to the beginning. Hit the wrong logo.
To the
first page. And slide down a little bit. I think they have the cards here.
There's a place where I click on it and then it says, like enter your email or register. And then nothing ever happens.
That's what I'm trying to figure out.
Or that,
There it
I've
is.
played this, yeah, I've gone through this like probably 10 times in total and I gave up.
We tried one time, so I see what.
Now it'll work. Because the doctor is here.
I think I have them downloaded on my computer.
I just thought it'd be nice to have as a tool. I
we-
realize we're usually doing telehealth, but
We use this for the patient, the brain good access, and then there's a
Right.
video on the
it's
back.
really nice to have a video.
And then we have one now on brain gut behavioral therapies. We have one on neuromodulators. So. Yeah, there they are. Well, would some of you try it? And if it doesn't work, let me know. Here's the one on the neuromodulators. And send me an email and I'll get them to you. Okay.
Thank you, Doug. I think there was one last question. There are a couple questions in the chat box. One is there a utility of a referral to pain clinic?
The utility.
I'm sorry, is there a utility for?
For referral to pain clinic?
Okay.
Well,
And then the final, and then a question of, do you have a strategy to take advantage of the placebo effect?
that's what we're doing. Placebo is expectation and conditioning. And if you have a good relationship with the patient, and they expect that it'll go well, then that's how you do it. And it's the same thing with medications. If you have a good relationship with the patient, you're going to get a better response to a medication you prescribe than someone who just tosses it to the patient.
Okay. Thank you, Doug. And thank you, everybody, for joining online.
Thank you.
Thank you.
Thank you.